Hello, I am Rebecca Millman, Associate Professor and Section Chief of Radiological Sciences at the University of Colorado School of Medicine. I put together a brief presentation about radiation safety and risk in radiology, specifically discussing deterministic effects. So in this presentation, we'll talk about basic radiation dose units, radiation doses around us, and then talk about some of the deterministic effects from radiation exposure, including skin reddening and epilation, cataracts, fertility effects, and fetal abnormalities. When the topic of radiation comes up, for many people, these are some of the things that come to mind. Even people who work around radiation sometimes have an ingrained negative perception of it. It evokes thoughts of nuclear bombs, dangerous glowing objects, and mutated wildlife. People envision the Incredible Hulk or mutant cartoon turtles and are concerned that getting too many X-rays will make them glow in the dark. So what does this have to do with your role as a radiologist? Radiation safety is a vital component of your job. It's critical that you have a solid understanding of what the risks from radiation are, and perhaps even more importantly, what they are not. This enables you to keep yourself safe from radiation, optimize the use of radiation for patients, and provide accurate information to patients, parents, and caregivers that enables them to make truly informed decisions about their own health care. It also enables you to evaluate risks and benefits of imaging exams and procedures, including any special considerations that may need to be made for pregnant patients, pediatrics, or for patients undergoing repeat imaging. In this talk, I'm not going to go into detail about different types of radiation units, but I will describe those that are used in the presentation. The first is organ dose, or the amount of energy deposited per unit mass in a particular organ. It has units of milligray. The other unit is effective dose, which has units of millisieverts. Effective dose is a quantity that was developed for radiation protection purposes. It accounts for differences in the types of radiation and differences in types of tissues. So it accounts for radiosensitivity of a specific organ, and it accounts for the type of radiation that it's being exposed to, so X-rays, alpha particles, etc. Effective dose is useful for comparing the effects of radiation from different types of radiation and exposure to different parts of the body. It's often used to evaluate risk to a population, although it's inappropriate to use effective dose to determine risk to an individual. Another note is that effective dose is usually based on age and sex averaged radiosensitivities, so that also needs to be recognized when interpreting that value. There are also modality-specific dose metrics that you may be familiar with. In CT, we talk about CTDI or DLP. In fluoroscopy, we talk about air kerma or dose area product. In mammography, we talk about average glandular dose. In nuclear medicine, we discuss injected activity. I'm not going to talk about these dose metrics in this talk, but I want to point out that none of these dose metrics actually describes the radiation dose to a patient. They're all ways of describing the amount of radiation used in various exams, but they do not describe patient dose. Before we start talking about radiation risk, it's useful to have a sense of how much radiation we're exposed to from various sources. Most of our food is naturally radioactive. Bananas contain small amounts of radioactive potassium. It's a small amount, about 0.001 millisieverts, so you'd have to eat a lot of bananas before the radiation posed any health risk. And well before that, you'd probably be pretty uncomfortable. We can compare this with the dose from a routine chest X-ray, which has an effective dose of about 0.01 millisieverts. A transatlantic flight will expose you to about 0.04 millisieverts. And a standard screening mammogram, 2 views of each breast, has an effective dose of about 0.34 millisieverts. The average background radiation in the United States is about 3 millisieverts per year, although it's about twice that in Colorado, about 6 millisieverts per year. That's due mostly to uranium that occurs naturally in the soil and decays into radioactive radon. So let's talk a little bit more about radiation for medical imaging. This pie chart shows the sources of radiation exposure in the U.S. in 1980. The average amount of radiation that people in the U.S. receive for medical imaging was about 15%, or 0.5 millisieverts per year. By 2006, the percentage of radiation exposure that was from medical imaging had increased substantially to 48%. About half of this medical radiation exposure was from CT scans. When people show these charts, they're typically using them to point out this increase in radiation exposure due to CT exams. It's almost always used to raise the alarm about overuse of CT and also to cry out for the need to further reduce the amount of radiation that's used in performing CT exams. But that's not the only way to interpret this information. Consider what was happening in the world of radiology in 1980, when medical radiation per person was only about 0.5 millisieverts per year. CT was still a pretty new technology. In 1980, there were about 3 million CT scans performed in hospitals across the US. And CT was mostly limited to head exams due to technical limitations. CT exams of the body, including cardiac CT, were not widely available until later. In 2006, there were about 67 million CT scans performed, a huge increase over the previous 26 years. So obviously more people were getting CT scans, and the average American's exposure to radiation from CT increased. But is this a good thing or a bad thing? As I mentioned, this information is typically used to argue that we need to reduce the amount of radiation used during CT exams. But we could also draw some very different conclusions. For example, this information suggests that CT imaging is more readily available across the country and that more Americans can benefit from its diagnostic capabilities. So it brings up the question, is radiation good or bad? My answer is that it's neither. The radiation used in medical imaging is not inherently bad. It is a tool that's used to aid in diagnosis and improve treatment of disease. It can certainly have damaging effects, but the goal of radiation safety in medical imaging is to ensure that the benefit derived from the use of radiation is higher than the risk posed by the radiation. And keep in mind that CT largely replaced exploratory surgery as a diagnostic tool, and that regardless of what risk model you use, which we'll discuss in a little bit, the risk from CT radiation is still much less than the risks associated with open surgery. So radiation is not necessarily good or bad. It's all in how you use it. And the goal of this discussion is to help you use it for good. By 2016, there were even more CT scans being performed, about 84 million. The average dose per exam decreased, however, also decreasing the average exposure for medical radiation during this time. This decrease was widely praised, but we have to ask the question, is this decrease inherently a good thing? The real difference here was not a decrease in the number of scans performed, but in the dose per scan. But as the pressure to decrease CT doses, and doses of medical imaging in general, increases, we must be sure that we're maintaining adequate image quality. And that's one thing that these charts don't address at all. In fact, image quality is often left out of conversations about radiation and medical imaging altogether, although it's vitally important. I mean, if the image quality is so poor that we can't confidently make an accurate diagnosis, then there's no point in having done the imaging at all, and all of that dose is essentially wasted. So for all of these reasons, I will never talk about radiation dose reduction as a goal. Rather, I will discuss the optimization of how radiation is used in medical imaging. So, where does radiation safety apply in medical imaging? It applies to patients, parents, caregivers, staff, and the public. In the previous talk about radiation biology, I discussed what happens when radiation interacts with cells, and I touched on some effects radiation can have on tissues and organs. I'll expand on that here. Radiation tissue effects are also called deterministic effects. They're caused by killing a certain number of cells. Examples of tissue effects include reddening of the skin, epilation, cataract development, decreased fertility, and fetal abnormalities such as microcephaly and organ malformations. This is an example of a skin burn that occurred after the patient underwent a fluoroscopy-guided procedure. These injuries were due to substandard patient positioning, resulting in the patient's arm and sides receiving higher dose than they should have. This is an example of a severe tissue effect. This 40-year-old male patient was exposed to large amounts of radiation as part of multiple fluoroscopy-guided interventional procedures performed in a single day. We can see that there are different tissue effects that manifest at different times after exposure to radiation. On the left is a photograph taken 6 to 8 weeks after the procedures. We see some skin reddening. This is a classic appearance of a radiation-induced skin injury where we can see the well-defined edges of the radiation field. By 16 to 21 weeks after the procedure, a small ulceration had formed. Much later, 18 to 21 months after the procedures, a large area of tissue necrosis is visible. This patient required a skin graft. One thing I want to emphasize here is that this is an extremely rare example. These things can happen, but they don't happen very often. And even more so it's even more rare than in the past because there's much better awareness about radiation effects, especially in fluoroscopy. There are also improvements in technology, and particularly in image processing, that have resulted in lower dose rates in fluoroscopy. Another thing I want to point out is that under normal conditions, this sort of skin effect is not seen outside of fluoro-guided procedures. And even then, it's seen very, very rarely. And lastly, while this is an extreme example, and the previous example was due to an error in patient positioning, skin injuries sometimes happen even when the operator does everything quote-unquote right. The gentleman shown here underwent multiple coronary procedures on the same day, without which he may not have survived. So sometimes skin injury is an acceptable outcome, although again, this is an extreme example. All of that being said, sometimes radiation-induced skin injuries and epilation are preventable and due to machine or operator error. This image shows a patient who had a brain perfusion CT scan. You can see that over part of the CT scan range, she has hair loss all around her head. This was due to machine errors in a group of CT scanners around 2010. This other image on the right shows skin reddening that appeared on a 2-year-old patient in California after a head CT. This was due to gross incompetence of the CT operator, who repeated the scan many, many times because the patient was not staying still during the scan. Investigations showed that he received the equivalent of about 200 CT scans. Some things to note about skin effects. It takes about 2 months for skin to repair and regenerate, so exposures over a 2-month period have cumulative effects. And exposures separated by more than 2 months are not cumulative. Temporary skin reddening can occur at doses as low as 2 gray, and more severe effects at doses as low as 6 gray. However, as I mentioned in my previous presentation, the majority of the population will not experience skin effects unless they're exposed to higher doses. Some factors that can make patients more susceptible to developing radiation-induced injuries of the skin and hair include genetics, and the contributing factors here aren't fully understood. Obesity, any disease that impairs tissue perfusion, and some medications can also increase radiosensitivity. So what risks are posed to patients and what can we do about it? Patients are only at risk during prolonged fluoroscopy-guided interventional procedures unless there's a machine or operator error. Thresholds for skin effects in pediatrics are similar to those for adults, so while kiddos are more susceptible to some radiation effects, this isn't one of them. We can reduce risk to patients by understanding how to optimize radiation dose, including the use of pulsed fluoro, pediatric and size-specific protocols, and proper collimation. The patient's medical history should also be reviewed to check for previous fluoroscopy exposures over the previous 2 months. This can help guide the fluoroscopy operator as to whether adjustments should be made, for example, rotating the X-ray tube to minimize the amount of skin exposed during multiple procedures. And as a last note, do not place lead shield on patients. At best, it doesn't do any good, and at worst, it makes your images look crappy and can increase dose of the patient. Parents and caregivers are at no risk of deterministic effects, even if they're holding a child during an X-ray exam or in the room during a CT exam. Staff are at risk of skin reddening and epilation if parts of their body are routinely in the primary X-ray beam, so try to minimize this. Sometimes getting your hands in the X-ray beam for short periods of time is very difficult to avoid, but avoid it when you can. Another note is that epilation has occurred on the lower legs of fluoro operators because this part of their body is near the X-ray tube and not always protected by table drapes. Ways to reduce risk to the staff include wearing a lead apron during fluoro-guided procedures if you're within 2 meters of the patient. Also, wear your radiation dosimeter and wear it appropriately at collar level outside of your apron. Like this, handsome fellow. The last way to reduce risk to staff, risk to yourself, is to optimize patient radiation dose. All of your exposure, or the vast majority of your exposure, is coming from radiation that's scattered within the patient. So anything you do to optimize patient radiation dose will also optimize your own exposure. The next type of tissue reaction I'll discuss is cataracts. Unlike age-related cataracts, radiation-induced cataracts typically occur in the posterior subcapsular region. The threshold dose for developing cataracts is thought to be about 500 milligray. Patients who may be at risk of developing radiation-induced cataracts include those who undergo repeat imaging that exposes the eye to high amounts of radiation, such as head CT. This risk can be reduced by limiting the scan range to that needed for clinical care. In other words, don't scan parts of the body that you don't need to see. Another feature that's become more common on CT scanners is organ-based tube current modulation, where the tube current is lowered as the X-ray beam passes over the patient's eyes. A word of caution when considering implementing such features. Always verify manufacturer's claims about dose and image quality. In the past, the dose savings have been exaggerated and image quality effects not mentioned. And this is one place where your friendly local medical physicist can help you out. Regarding risk to staff, fluoro operators are at risk of developing cataracts. One way to mitigate this risk is to wear lead glasses. You should also be sure to wear your radiation dosimeter and to wear it appropriately. I know I mentioned this just a minute ago, but it's important, so I'm mentioning it again. Of course, these dosimeters only give you information about your exposure retrospectively, but it's useful to know what your typical lens exposure is. Another thing you can do, again, is to optimize patient radiation dose. So doing things like collimating to the anatomy of interest will also decrease your dose. And finally, time and distance. Your dose will be lower the farther you are from the patient and the less time you spend around the X-ray beam. I discussed radiation effects on fertility in my last talk, but as a reminder, fertility is not affected at diagnostic doses. Another thing I want to mention is that radiation has never been shown to cause hereditary effects in humans. While we often hear people say they're worried about radiation exposure because they think it will negatively affect any future offspring, there isn't actually any evidence that this is true. Unfortunately, this myth has been perpetuated for over 100 years based on experiments performed on fruit flies. But humans are not fruit flies. So there's zero risk to patients, parents, caregivers, or staff's fertility. And as another reminder, do not place lead shielding on patients. UC Health policy is to not place lead shields on patients' gonads, and this applies to all patients, including women of childbearing age and kiddos. The last deterministic effect I'm going to discuss is fetal abnormalities. This includes pregnancy loss, as well as reduced mental capabilities, microcephaly, and other physical abnormalities such as missing limbs or underdeveloped anatomy. When considering radiation risk to a fetus, it's important to consider the baseline risks. Pregnancy loss occurs in about 20% of pregnancies. Some estimates of this are even higher, around 30%. And congenital disability occurs in about 3 to 5% of births. Radiation can increase this risk, but only at fairly high doses. There's a demonstrated increased risk with fetal exposures to acute fetal exposures above 200 milligray. Below 200 milligray, there's been no observed increased risk. The exact risk and the most likely effect depends on the stage of pregnancy at the time of exposure. Since radiation exposure to a fetus presents a unique circumstance where there's radiation exposure to someone other than the patient, it's worth looking at a little bit more closely. In imaging pregnant patients, there are two different scenarios regarding fetal dose, and I'll emphasize here that I am not including nuclear medicine in this. The first scenario is that the fetus is outside the imaging field of view. In these cases, the dose to the fetus is minimal. Even for a chest CT of the mother, the fetal dose is below 1 milligray, well below the level where there's any known risk. The second scenario is when the fetus is inside the imaging field of view. In these cases, fetal dose is higher, although for radiography, doses are still just a couple of milligray at most. Even for a relatively high exposure exam, a CTA pelvis, the fetal dose is about 20 milligray. Again, this is the point below where there's any known increased risk to the fetus. This doesn't mean we want to be totally cavalier about imaging pregnant patients, but you have to know what these doses are and what the associated risks to the fetus are in order to help patients and other providers make informed decisions. So in summary, the primary tissue effect that's of concern to staff is cataracts. This risk can be mitigated by wearing lead glasses if you're working in fluoroscopy room and by optimizing patient dose. Use fluoro safety precautions, including hanging shields and lead drapes. And finally, limit the time you're near the patient, and if you aren't needed at the bedside, take a few steps back. The primary concern for patients is radiation-induced skin injuries, but practically, this is only seen for extended fluoro-guided procedures, and even then, very, very rarely. Ways to mitigate this risk include understanding the controls and features of the fluoro unit that you're using, understand what pulsed fluoro is, and what pulse rates are appropriate for various procedures. Collimate so that you're only exposing anatomy that you need to see, and only image when you need to. And only use higher dose rates, such as DSA, when needed. These tools are there for a purpose, and you shouldn't avoid using them altogether, but they should be used appropriately. So that provides a brief overview of deterministic effects that are relevant to medical imaging. If you have any comments or questions, feel free to reach out.